Welcome to the SBI Summer Series. Today is July 13th, 2022, and we're going to be talking about patient-centered reporting and communications. For anybody who's first joining the SBI Summer Series for the first time tonight, welcome. The SBI Summer Series is run by the Social Media Committee from the Society of Breast Imaging. And the purpose of this is just for us to have a conversation around topics that are important to breast imagers and even sometimes to patients or to our referrers. It's a casual conversation. I have a great panel tonight and a great topic. So I just want to start just by introducing myself. I'm Nina Vinkoff. I am the chief of breast imaging for Northwell Health, which is in the New York metropolitan area. And I'm also the vice chair of our department for patient experience. So this topic is like right in the crosshairs of the stuff that I love the most. And I'm just going to let all of my panelists tonight introduce themselves. And we can just go sort of around the circle, starting from me. And go ahead.
All right, I guess I'm up. I'm Rachel Pricer. It's nice to have you all join us tonight. I am in private practice in the Midwest, have been my whole career, and I'm transitioning to a new role in a couple of weeks. I'll be director of breast imaging for Mercy One Northeast Iowa, so it's exciting.
Excellent.
Very exciting. I'm Toma Omofoye. I am associate professor of radiology at MD Anderson Cancer Center in Houston, Texas. Excited to join you all tonight.
Hi, I'm Sandy Lee. I work at USC, University of Southern California. I'm also the program director for the Breast Imaging Fellowship here. And I'm also a colleague of Dr. Linda Larson, who's also on the panel tonight.
Great to have you.
Hi, I'm Margaret Jacobozzi. I'm a breast imager at Wake Forest, and I'm also the fellowship director there.
Excellent.
Hi, I'm Linda Larson, and I'm a radiologist breast imager at the University of Southern California with my colleague, Sandy Lee, and I'm very happy to be here.
All right. We have a great panel from all across the country, so this is going to be a great conversation. I wanted to start by just sort of kind of doing an overview of what do I mean by patient-centered reporting and communication, and then we'll just dive right into talking about it. In radiology in general, for pretty much most of the history of radiology, the way that reports were written were meant to be a communication between the radiologist and the person who was sending you the patient, but not the patient themselves. The exception to that actually is in breast imaging, which we'll talk about. But things have really been changing in recent years. As you all know, patients now can see the reports online, and there's been legislation that is changing things as well. So with the 21st Century Cures Act, patients are now going to have access to the reports basically as soon as they're signed without any kind of delay. And so now we're talking about patients who are not only getting a letter in the mail that was intended for them, that was maybe written in patient-friendly language, but they're actually going to be reading the original report that was written really with a referring physician in mind, that was written maybe in language that wasn't originally intended to be for a patient. Mm-hmm. So that's kind of the background. And also to say that breast imaging has been ahead of the pack when it comes to patient-friendly reporting. We've been sending out lay letters to patients with their results since the beginning of MQSA, back ages ago when I was in the early days of my training, and probably none of you even remember a time before there was MQSA. So for us, this is natural, but there's still, I think, topics that come up around how we can make our reports best suited for patients. So I wanted to start by just talking about screening mammograms and how do you give patients the results of their screening mammograms? Are you reading your screening mammograms online, or are you reading them batch? So let's just start with that. How are you reading them, and how are you giving patients the results of their screening mammograms? And we can just go around. Anybody who wants to talk can just jump right in.
Sure.
I think there's a bit of variability. I'm sorry, I didn't mean to.
No, go ahead.
No, go ahead, Toma.
There's a bit of variability in our practice, but one of the things that we offer in our practice is real-time results to patients. So any patient who presents for a screening mammogram can opt into that service and request receipt of their results real time, which typically means then that the radiologist has to read it real time instead of in a batch, and will then go and speak with the patient about their results. So that's been a recent addition to our practice, and patients have really welcomed that.
But they have to request that in advance before they come in for their appointment, or they can decide while they're there.
They can just decide while they're there. So it's just built into the workflow. And so it's part of our radiologist assignment that you know that in this rotation, you might have real-time results patients.
And when you're giving real-time results, do you have a staff member transmit the results to the patient, or those patients actually get an opportunity to speak to you, to speak to the physician?
The vast majority of the time, the patients get an opportunity to speak to the physician. What will sometimes happen is if the radiologist is tied up in two things, for example, and says, okay, this is benign, but they're going to have to wait for me for 7 minutes for me to come in and give it to them one-on-one. Sometimes in those scenarios, the staff member may communicate to the patient, it's benign. You can still wait to talk to the radiologist if you want. And sometimes they wait just to hear it. But by and large, we're giving the results ourselves.
What if it's a BI-RAD 0? What if it needs a callback? Then what do you do?
Yes, so that's a great question. When it's a BI-RAD 0, patients are even more appreciative. And there was a study about this years ago where patients indicated they wanted to know their results as quickly as possible, even if that meant it was an abnormal result. They would rather know on the Friday versus on the Monday when you could be scheduled immediately. And I'll say anecdotally in my practice, I found that to be true, that even when it's BI-RAD 0, the patients are really grateful to have that news. I think as human beings, there's always this fear of the unknown. Mm-hmm. And so even if it's a result that's unexpected and maybe even unwelcome, there's a gratitude in knowing it as quickly as possible. I think what Linda's getting at is that do those patients feel more likely to, are they more likely to pressure us into trying to get them in sooner? And the answer is yes, because they're human and we're human. So as much as possible, we do try to work them in very quickly for their diagnostic workup. It's hard to look at the face of somebody who's worried and, you know, not do everything you can. So as much as possible, we try to accommodate that. And even in the instances where we can't, they're still grateful to receive the news firsthand from a radiologist.
Yeah.
We have never, I mean, we do give results in a similar kind of a way. We don't have it structured as nicely as you do, but whenever we're giving real-time screening results, we always do the conversion to diagnostic if they need it. I've never said to a patient in person in the office, you need to come back on another day to have the additional images. I'm not sure our patients would accept that. I've never even tried to do it, to be honest. I've always assumed that if we're going to give the patient the results live, that we've also taken on the responsibility for taking the additional views. Is anybody else doing anything like that?
I think that we have to keep in mind that the patients themselves are sometimes also add-ons to the schedule. So if you had a patient who's from out of town, for example, who's here for other imaging and tries to be added on for a screening, and then you're trying to add on a diagnostics, sometimes we can, but even when we can't, they're still grateful because generally it meant that somebody took the time. And when you have that firsthand one-on-one conversation with the radiologist, the information is couched appropriately. So we can say to them, this does not necessarily mean you have a cancer, right? Mm-hmm. This is the percentage of time where people are called back from a screening mammogram for additional views. And even that, I think, is really reassuring for them.
No, I agree. I'm sure. And I've just never tried it. Is anybody else on this call doing real-time screening?
We do on occasion. That's not our kind of MO, but if someone requests it, or if, you know, it's a patient that I've followed for years and I know she's going to be anxious, I will make sure that she gets her results before she leaves. We do have a program called our Executive Health Program where we actually schedule in time for diagnostics if necessary. These are patients who are in our health system and getting all of their preventative care for the day in one bulk setting. And so we always put their screening mammogram first thing in the morning. And if they need any diagnostics, that gets tacked on at the end of the day. So that's kind of a unique population where we are able to kind of do that for them in a scheduled way. But I agree with you, Nina. It's really hard to turn away a patient when you're saying, oh, there's something here. And I'm going to have you go home and sleep on it. So I think that's something that is a holdup for a lot of people in operating in that way.
Yeah.
So while we're talking about screening, who, if it's not in the office, if it's not you saying to a patient, which is certainly ideal, and explaining to them right there and then that they're going to need to have additional imaging, who calls your patients for screening callbacks?
So at USC, we keep a list of BI-RAD zeros, and at the end of the day, when the technologist has some time, they will make phone calls to patients usually for biozeros done the same day or the day before, to tell them that there is a finding that we need additional views and to schedule them to come back. So
you have text calling. Does anybody have anybody other than text calling? Does anybody have a staff member that isn't technical calling?
But we have our navigator calls. So, and she's very good at kind of communicating and kind of reassuring patients. So she calls our callbacks.
She's a nurse?
She's actually trained as a tech, but she's been in our navigator role for a while.
Okay. And did either of you, did you write the scripting that the navigator or the technologist is going to use when they call? Or are you just kind of giving them guidelines of what to say? Or are you just letting them, make up their own speech?
I'm not familiar if there's like an original script written out, but I do know whenever I hear the technologists call them that it's also always the exact same phrasing that they use.
Okay.
But I'm not sure how it initially started out.
Okay.
We
just transitioned. It's really interesting. We used to have nurses call, and I actually had scripting for them. They didn't have to read it word for word, but I listened to too many conversations that I didn't like. You eavesdrop and you hear the things that are being said, and you're like, no, that doesn't work for me. So I gave them some ideas, some guidelines of ways to phrase things. But what we didn't like about it is they couldn't do the scheduling. So there needed to be like a second phone call. Like they would give the patient the results and then pass it off to scheduling. And then there'd need to be a second phone call where the scheduler would actually reach out to the patient to schedule. So I recently switched it over to a group of people who are not technical and not nurses, who can actually call you to tell you that you need additional views and schedule you right there and then on the phone. And so far that's working.
Yeah. And that's what our tech does at USC. She calls and schedules it at the same time. So that works out very well.
Yeah, I think they really appreciate being able to get the appointment, to not just get the news, but to actually get the appointment. So, so you mentioned that you're at about a day or maybe the day before that you're reading your screening mammograms. Are all of you as up to date with that, with your screening mammograms? What's the typical delay between the screening mammograms and when you have them interpreted?
For us, at most, it's 24-hour turnaround unless it's done Friday afternoon and we're not there, so we'll read it early Monday morning.
Same with us.
Yeah.
Yeah,
It's amazing. It's amazing that we all hold ourselves to that. We hold ourselves to that too. And, we actually read through noon today because I don't like people to feel like the day never ends. So I'm like, we stop reading at noon. So we're usually reading from noon yesterday to noon today is sort of how we handle our screening mammograms. But I feel like breast imaging stays closer on top of the work list than pretty much, at least in our health system, any other part of our department. Like, look what's going on in like MSK. Or even body a lot of times if it's not an urgent study. And, we're up to date on today. They're like
our mammogram read in 24 hours.
We read up till 4 p.m. same day. So, and a lot of the times, if you only have a few scheduled after then, often the radiologist will just stay and read them because they might want real-time results as well. So it all we're pretty much close to real time for our screens.
Yeah. It's amazing. I mean, I think that breast imagers in general hold themselves to a higher standard than pretty much anybody when it comes to this kind of stuff. So what about diagnostic results? So you have a patient in the office and they're going to need to, I know if you're recommending a biopsy, I'm assuming probably everybody goes in and speaks to the patient if you're recommending a biopsy. But what if the results are normal? Or what if it's a 6-month follow-up? Is that something that you go in and talk to the patient? Or do you allow a technologist to convey that message to the patient? How does that work?
The doctors go talk to the patients for all the diagnostics at the Norris Breast Center. The doctors go in there and give the great news, it was fine, or probably benign, or you need a biopsy. So it's always the doctor talking to the patient. Now at county, where we have a much larger number of patients a day, it's usually the technologist who talks to the patient, but we'll schedule the biopsy before they leave. Okay. And we have one of the clerks doing that, who's been doing it for many years and is very good with the patients.
Does the technologist also tell the patient if they need a biopsy, or for that situation you would go in?
Yeah.
For that Is that pretty much how everybody else does it?
A little bit different in private practice because we sometimes have, 3 rooms going, most of those diagnostic, 3 ultrasound rooms, and you physically can't be in all those places at once. But I came from a place where you talk to every single person, even if it was absolutely nothing. So we kind of came up with a hybrid where I would talk to as many people as I could. Definitely the biopsies, but also the high risk people, young people, if it was their first visit, anybody who asked to speak to a physician. But I spent a lot of time when I first started in that environment going over with the technologists with my scripting. And I made them listen to my scripting on every possible scenario while I was in the room, whenever we got a new technologist, so that I felt confident that they were doing a good job giving that patient what they needed and acting as my surrogate. So it was tricky because I truly believe that every patient who comes in for a diagnostic should get to speak to a doctor. But in the reality of a high volume private practice where the scheduling just does not allow for that, you have to kind of come up with a nice balance.
Even in a not, I mean, I was like that when I was in private practice, but even where I am now, the big academic health system, there's not time to speak to every single patient. And I totally agree that I think scripting is really important. I think, especially when you have a large staff, I think it's really important that everybody understand how to convey these messages. And does anybody provide the patient with something written right there on the spot so you make sure that they know what their results are, or are you just letting it all be verbal?
I've done it both ways. I've been in places that do it both ways, and I am a big fan of giving them something because usually anxiety is high, even if everything's great, and they're not going to remember half of what you say. And so if you have the bottom line there, and it could just be a checkbox, everything looks good, they at least have that to reference back to when they have a moment to kind of exhale and think back over the whole conversation. So I'm a big fan.
I agree. When I was in private practice, we always gave them something. And then where I work now, they didn't, but I just converted us over to handing them something because too often patients would call me a couple of days later and say they didn't get their results because what the technologist would say was something along the lines of, you can go. Where what they really meant was everything looks fine. You can come back again in a year, but they weren't being explicit about it. And then the patient didn't understand that what they had said was, it's normal, you can come back again in a year. So now I make sure they walk out the door with something written that actually says that on it.
So you give them something and they also get the patient letter?
The patient letter is going to come in snail mail though, right? So it's the patient letter gets printed out of your tracking system. We use MagView, it's going to get printed probably the next day. Then it's going to get folded and put in an envelope and go in the mail and, end up at their house, 4 or 5 days later. So we do the letter because the FDA requires you to send them a letter. And I'm not totally sure that our written results actually takes the place of that. So I send them the letter in addition to that.
So a lot of the patients at the Norris Breast Center that Dr. Larson was mentioning, we're actually on the same floor as the breast surgeons and the oncologists. So we actually do have a written form, but it's actually not for the patients. It's to communicate our results immediately to the breast surgeon and the oncologist, who's going to see them in clinic immediately following the mammogram and ultrasound. So we write our findings, we check off the BI-RADS, and if it's something complicated, then we'll speak to the radiologist and they'll come speak to us. But it's not to the patient themselves.
So how does it get from you to the oncologist? The patient carries it there?
Our technologist will be the one to hand it off to them.
Interesting.
We're a hallway away.
No, that's really nice. That's the ideal, right? I mean, to be co-located like that is great. Yeah. That's amazing. All right. So now I have another question about what you send people away with. So do you tell people while they're there in the office about their breast density, or do you discuss risk with them while they're there? Or do you send them out with something about breast density or risk? I know we come from all different states, and so people probably have different, state regulations. Here in New York, the lay letter has to include a paragraph about risk. About breast density. But how do all of you handle that?
We're similar. I'm sorry. Go ahead, Margaret.
In our reports, every single report has a little paragraph at the bottom talking about breast density. And in North Carolina, we're one of the states that you're required to inform patients of their breast density, and also in the lay letter. And in our reports, we refer them to the North Carolina ACR website, the breast health website, where it gives some more information on breast density.
Do you ever talk to them about breast density while they're in the office, or provide any literature about breast density?
We don't provide specific literature on site, but we have kind of that website to refer them to. And certainly if they have any questions about breast density, we're there to answer it for them.
So we are a pretty high volume practice in terms of ultrasound. And Texas is one of the states that has density notification laws. So in addition to having the paragraph, we actually have more options to offer the patients. For example, the patients could get scheduled for a screening ultrasound, and sometimes we can add that on the same day. But we also have an undiagnosed breast clinic, a cancer prevention clinic, where there are practitioners whose entire role is just advising patients around cancer prevention, maintaining that screening schedule and their risk. And so we'll do both. We'll talk with the patient about their breast density, say these may be our recommendations. You may need supplemental screening, and we can connect you with a cancer prevention clinic as well to assess density and other risk factors that you may have. And that way there's somebody that's also reinforcing that conversation, because some of these patients who are high risk for breast cancer may also be high risk for other types of cancers as well, outside of my scope of practice. So it's beneficial to link them up with someone that can provide comprehensive care.
That's a lot of conversation to have while you're in the office. So tell me how you do that. Like, how, from a practical point of view, do you read their mammogram, give them the results of their mammogram, and talk about things like breast density and risk?
I think it's the same thing as everyone is talking about here. You have a script. So it's a conversation we're having all the time. So we have a script about it. When the patients come in and complete their history sheet, their intake, that intake includes a lot of the information already that helps to highlight the patient's risk factors, right? So you're seeing that, and then you're seeing the density. And so in this case, I think one of the things I love about breast imaging is we give solutions. We always have a recommendation. So it's wonderful that I can go in and say, my recommendation is you should consider supplemental screening. And I have someone who can help you kind of navigate this high risk assessment. Here's their card. You can set up an appointment with them. Sometimes they'll even work them into their clinic. So we always have a recommendation. We have our script that we go through, and then the next steps.
So for all your
Oh, sorry. Go ahead, Linda.
for your screenings, like let's say you have a screening with a heterogeneously dense or extremely dense, and she's normal, you're going to walk in there, you're going to say, oh, your results are negative, but I see you have dense breasts, and this is what I recommend.
Yes. So you have dense breasts. Do you know what that means, right?
Yeah,
So give them a second.
really-
The truth is now we're starting to screen millennials who have a very high health literacy. So a lot of them have heard about breast density versus I think even 5 years ago. So when you even say that, some of them will say, oh, yes, I've already heard about this. Or you can say to them briefly, well, this means that you have a lot more of the breast tissue in your breast, less of the fatty tissue, and that breast tissue can be harder to read through. Sometimes that can mask really small lumps. So for patients who have dense breasts, we do recommend that, or the ACR recommends that they consider adding on another screening modality in addition to their mammogram. So you always need the mammogram, but you can consider something else to add on. And then they talk about options.
I think that's really impressive to be able to actually do that verbally all day long. I can't imagine in our practice being able to do that. A lot of that stuff for us ends up happening with the results. So we have nurses calling, like I said, with our results, and they will mention things like breast density and also risk assessment. So, you know, we're doing a tyroacoustic risk assessment on every single patient that comes in. And so when the nurse calls you with the results of your mammogram, she can say to you, you have dense breasts or you're in a high risk category. That would be a really hard thing for us to do, to have the physicians having that conversation all day long. I mean, all that information is so important to transmit to the patient. I just can't imagine being able to have that conversation, with the exception of like the diagnostic patients that I'm in the room talking to, but for the screening patients, I can't imagine being able to have those conversations all day. Is anybody
That's what I was talking to Dr. Lee about earlier this week when we knew we were meeting on this panel. We said we'd really like to be able to talk to our patients, our diagnostic patients that we do see, and the ones we biopsy. At the very least, we can tell them about the dense breasts and But I think, not enough people know about it. And I don't know how many, they get the information from us through the letter. I don't know once they get the results, if they really read the whole letter.
Right.
Yeah.
I think that's a really important point. I mean, most states are doing something in their lay letters as a requirement. I think it's like 38 states now, but what is required is really variable. And in our state, we just have to tell them what it is, and they have no idea what that means. And so we get lots of questions with patients calling in asking, what does this mean? And so like Toma, I have taken to talking about breast density and risk assessment for every single patient I talk to. And I've gotten really efficient at it. It used to take me forever, and the techs were like rolling their eyes, but now I've gotten much more efficient at it because I know the main points, and I know kind of what I need to say to make them understand, but also to kind of minimize some questions. And then we can refer them on to the patient navigator. For me, bundling risk assessment and density together as a concept has really been helpful in my efficiency in discussing it, because if they're high risk, we can kind of get them going in that direction, get them same day point of service genetic testing if they're interested in that, set them up with a genetic counselor all right there while they're getting their mammogram. And then those conversations can happen throughout the process down the road. Whereas if they're at average risk and they have dense breast tissue, we can kind of focus in on that density conversation a little bit more and what that might mean for them. And the other point that I think is really important is talking about how you pay for all that supplemental insurance. We're in a state here where we don't have an insurance mandate. And so it's hard to talk to patients about their breast density, and their mammo might not be as good, but hey, your insurance isn't going to cover all the stuff I'm going to talk about next.
Yeah. And listen, I consider myself to be, I'm a lifelong New Yorker, and I love being in New York, but especially as a breast imager, this is the greatest state to be in, because not only we have an insurance mandate that says no out of pocket. So we don't even just have an insurance mandate that says it has to pay for, breast ultrasound. We have an insurance mandate that says no copay. So the only people in New York that have to pay anything out of pocket are people who have out-of-state insurers. So this is, so basically everything, screening, diagnostics, sono, MRI for high risk, all of that
amazing.
Is without patient cost sharing. So it makes it much easier to have those kinds of conversations when you're not making a recommendation for somebody for something that they're not going to be able to have, that's really tough. But interestingly, though, most of you guys are doing batch screening, which means that the majority of your patients are not getting the privilege of being able to talk to you and have this conversation. So how do we convey, I know how I'm doing it, I have my nurses doing it, but how do we convey that important information about breast density and risk assessment to the people that we don't get a chance to talk to? Toma, you're in the exception here. You get to talk to them. You get to talk to so many of them, but what do the rest of us do? Like, how do we convey that information to them? Is written information enough? Is this too complicated for written information?
Can I actually say something? And I think Rachel alluded to this a little bit. It's not actually just the screeners. Sometimes you have a patient who is diagnostic.
Yeah, of course.
And they come in because they worry that they're high risk, right? So they're coming in at 32 with pain, vague symptoms. It's a great chance to, even in that diagnostic setting, have that conversation. But now you've done a favor to that patient forever. And at her follow-up screening, whenever she does begin screening, the conversation is more concise, right? So I think that all of the opportunities that each of us use to communicate with our patients benefits the patients and the follow-up providers going forward.
So basically, to paraphrase what you just said, to look at every patient interaction as an opportunity for education. And I think that's a really good takeaway message. I think, there isn't probably enough time to talk to every single patient, but every patient that we do get a chance to talk to is somebody that we can educate, whatever the scenario is that we're fortunate enough to be able to have that direct interaction with them.
And I think that's the way we should move forward, is talking directly to the patient instead of, or in conjunction with the referring physician or the other clinicians. I think we just need to deal with the patients directly, because no one's going to take better care of them than we are. So, and no one's as knowledgeable about breast density and risk factors as we are. So I think the communication should be directly with the patient.
And when we're talking beyond breast density, but about risk, risk sort of separate from breast density, do you all feel that that's a space that and this is kind of a leading question because I think we probably all feel similar, but do we feel like this is the place that we belong in, or do we feel like this is a place that some other practitioners belong in? You know, who should be talking to patients about risk?
I think everyone should be talking to patients about risk, but I think that we are uniquely situated to catch the most. You know, we see hundreds of women every single day, and if we do a Tyrer-Cuzick on every single one of them, we're going to catch something, right? And, you know, another provider in an OB-GYN clinic or PCP, they may only see a handful, a fraction of that a day. So we are seeing a higher volume of women, and we are the place they're coming. We want to catch those people who don't have any problems before there is a problem to catch. So you know, that's something I feel very strongly about. It's something that I've implemented into my practice when it wasn't there. And every single person who walks through that door gets a Tyrer-Cuzick, and we start that conversation.
Yeah, I implemented that as well, and I feel really strongly about it as well. I'm now at the point where I just want to figure out how can we get risk assessment for the people who are in the pre-mammography age, right? Like that's the latest thing that's just, you know, we have our organization saying that everybody should have a risk assessment by the age of 30. That's like pre-mammography. So like, how can we spread that message to our colleagues that are seeing patients before we even get an interaction with them so that we can start to identify women in their 20s? You know, I've sort of been the champion for that in our health system of saying, you know, I can't do it. I'm not going to see them when they're in their 20s. You know, it needs to be, I think, a part of well care for women, whether it's at their OBGYN or their internist or primary care practitioner. We can only talk to patients about risk when they've already decided that they're going to come in and have breast imaging, which might for some people be too late. You know, if they're not told to come to us until they're 40, and now we suddenly discover, you know, that they were high risk all this time and didn't realize, you know, we can do better than that, I think.
I think, and so there was a study by, I want to say it was the MGH group. I think Randy Miles was on there, and Anna Narayan and Don Chose, but they talked about a clinic in which the radiologist was a consultant for high-risk patients, and it had remarkable results in terms of targeting vulnerable populations. It was extremely beneficial, especially for vulnerable populations, that the radiologist served as the one who identified this patient as being high risk and got them plugged in. And it was just a really beautiful way of seeing how radiologists can impact healthcare disparities, you know.
We need to be in that space for sure. All right, I want to move on to the next topic because it's kind of a biggie, which is biopsy results. How do all of you give patients biopsy results? Who does it? How does it get conveyed? Is it by phone? Is it in person? Is it not even you? Is it the people that send you patients that get to be the ones to deliver that news? How does that happen where you work?
Well, when we have, I think Sandy can tell you more about Norris, but we have a community hospital we're affiliated with. And we used to call and give the biopsy results to the patients, and the referring physicians did not like that. They wanted to be the ones to give the results to the patients. So at the community hospital, as soon as we see the results, we call the referring physician and tell them to let the patient know. But it's and the same, I guess, at Norris, because a lot of the patients we see are coming from the clinic with the surgeons and the oncologists. So it's their patients that we're biopsying, so they also give the results as well. But if we know the patients and they call us, we'll give them the results. But it's usually the referring physician. Is that right, Sandy? I think in our
Yeah, exactly. And then at our third site, which we do a lot of biopsies, is at our county facility, and to make sure that they don't fall through the cracks and that we're not relying on the referring physician to see the result and then call the patient. We refer all of them immediately to our breast surgical oncology clinic. So they all get an appointment right away to go in person to be told the results and the further steps.
Okay. I mean, I think it's hard to trust people who are not breast imagers to convey some of the things that we have to explain in breast biopsy results, right? I think it's really, there's a lot of gray area in the middle, and it's hard to even train yourself to be able to speak in a coherent way to patients about things like LCIS, atypical lobular hyperplasia, and then to expect that information is going to get transmitted correctly by someone who doesn't do this for a living. That worries me. I'm lucky enough to be in a place where our primary care, and I'm not talking about surgeons who I think are very obviously capable of conveying that kind of news. When patients are coming out of primary care, I think that we should be the people to be giving those results. I don't know how the rest of you feel, but I feel like unless somebody has been trained to discuss some of these entities, these are difficult conversations to have.
I think the other thing that comes into play with it, at my institution, the radiologist gives the results over the phone to the patients. And before we do that, though, we're doing the rad path correlation. So we're making sure everything makes sense. And I think in those rare instances where there's a discordant result, having the radiologist call and explain it to the patient is all the more important to really help the patient feel like all their questions are answered and really be able to explain what it all means and how to move forward.
And that's what we're doing. We're starting a telemedicine. So after the biopsy, before the patient leaves, we're going to schedule a time, either 5 days or a week later, to meet with the patient. So we're going to have one of the techs schedule the patient for the biopsy.
Nice.
We're going to get the link, and then the radiologist will set the time.
And it's going to be a FaceTime kind of thing. It's going to be a video conversation.
Video conference. And then wherever we are, we can just click on the link and talk to the patient. And that'll be after we do our rad path correlation.
There's two things I love about that. First of all, I think it's great to do face-to-face because, as all of you guys know, one of the hardest things about giving results over the phone is not really understanding how the patient is receiving the results, especially if they're a quiet person. Sometimes silence is the worst because you just don't know how they're receiving the information. So I think being able to make eye contact is great. But the second thing you said here is the thing I like about it the most, is the fact that there's an appointment. I don't know about all of you, but I'm trying to squeeze these conversations into all crazy parts of the day that might not be ideal. And the fact that you can actually set aside time and a person to do that, and it's protected time on the schedule that everybody's expecting, is really nice.
And protected time for the patient as well.
Yeah.
It'll go in MagView and then as a consultation, I think, and then in PowerScribe, we're going to have a template.
Okay, I can't wait to hear more about that.
Yeah. So I'll let you know how it goes.
Is anybody else doing anything like that, where they're actually setting an appointment with the patient to get the results?
Not an official appointment, but I would always just call people over my lunch hour. So I would tell them, if your path results are available by noon tomorrow, you will expect a call from me between noon and 1, because I knew that would be a time where I could be protected and not interrupted. And then I said, if they're not available by that time, you'll get a call from me after 4:30. And so I set that expectation of when they're going to hear from me. And I always call them the next day. Even if I don't know anything yet, I'll call and say, we don't have an update yet. And so that way I can at least assess if they're having any complications. Wonderful. And I was the only person in my practice doing that, but I felt
really
very strongly
impressive
that if I put a needle in somebody, I need to talk to him the next day.
It's really impressive that you have a lunch hour, but it's also really impressive.
No, I was
but it's also really impressive that you're handling that from a patient
but it's a lunch hour where nobody is going to come knocking on my door. I'm still working through it.
Of course.
but
I don't even
I'm
have
working
one where
through it
people are knocking on the door. So Mitva Patel, our fearless leader of this committee, actually just put a question in the chat, which is, how long are your telemedicine appointments going to be? Have you thought?
They're going to be 15 minutes, but obviously if they need to be longer, we'll go half an hour at most. But
wow, half an hour would be long. I'm not that.
Yeah,
that
15 minutes is our goal.
Wow.
Yeah.
I really, honestly, I think that's a great idea, and I think it's something I'm going to try to work on and seeing whether there's a way we could, especially in today's world where people are so used to, like, telemedicine became a thing in the course of the past couple of years. Like, if we had this conversation prior to COVID, that would seem really out there. But now that feels like a natural way to be able to handle these conversations. I love that idea. So now here's a question for you all. Do you give specific training to your residents and fellows about how to deliver difficult news, and how do you do that? Anybody? All right, well, I'm going to speak first and I'll let you think about it. So we do actually provide specific training. We have lectures that are specifically on this topic, but we also do a role-playing thing where we actually have our fellows call various different members of our department who act like various different kinds of patients that you might get on the phone, whether it's the angry patient, the scared patient, the patient in denial, the patient who doesn't say anything at all, the patient who's crying. And we have them give results while we're listening in and can give them feedback.
Yeah.
Anybody else do anything similar to
So
that?
at USC,
Sorry, go ahead.
at USC right now, we don't have something formal like that, but that's a great idea. I would like to start something like that.
It's super embarrassing for them, but we try to make it fun. We basically have like a room full of attendings that are listening in on this phone call, and every people have been assigned various different roles, but it's I think it takes a lifetime, I think, to be able to handle all the different kinds of situations that are going to come up in these conversations. But I do think it's helpful to have people kind of give you their tricks of the trade of like, here's what I do when something like that happens, So that's what we've been doing. Because of my role in our department, I actually do a lot of lecturing about patient communication, about how to not just deliver difficult news, but how to even deliver things that maybe might not sound like difficult news to us, but are, which is just that you need a biopsy, or sometimes just that you need additional images. Like those are all like conversations that I feel like people need to be trained to do. It doesn't come naturally always to have those kinds of conversations. You have your trainees call patients with results, or is it always you?
I'll say something for the last question and then I'll jump in here. We actually have lectures on patient communication, and real time you get to also assess the trainees. But I recently came up with a game and I'm piloting it with our fellows for this. So I'll let you know how it goes in how we do the communication. But it's a little bit similar to what you're doing, but wanted to put some fun in it because it is a stressful situation. I think for our practice, we are so well integrated. Majority of our patients are coming to MD Anderson because they want full spectrum MD Anderson care. So they typically already have, a breast surgeon, they're already assigned an oncologist, they're already assigned a cancer prevention doc.
Right.
So a lot of the time when the biopsy results come in, we do the right path concordance, talk with that clinician, that provider, who will then call the patients with the results. Because the advantage, as much as I love communicating with patients about their results, the advantage when they get the call from their physician is that they get the next step. I can see you in for your appointment, Tuesday at such a time. I can get you scheduled for surgery in 2 weeks, that sort of thing, which is beneficial. But the patients also know they can reach out to us on electronic health portals and such. So our trainees end up having a lot of practice communicating with the referring providers.
Anybody else? I think did somebody else want to say something? I feel like I cut somebody off.
Mm-mm.
No. I think, it's there's pluses and minuses of both. I think for me, I prefer to give the patient the results, but I do think it's really nice what you just said about making sure that they're not going to get dumped after the end of that conversation, that they're going to be able to, not just know what the next steps are, but have help in the next step. So we have navigators that take over. When I sign off a case in MagView, it goes onto a list that our navigators pick up, and they usually call people right away as soon as they see that there's either a high risk or malignant pathology. So I can usually pretty safely say to patients, you're going to get a phone call very soon from navigators. And if you don't hear from them, call them yourself. Like, here's their phone number. We have a nice, easy phone number to remember. And I'll just say, call them yourself if you want to sort of get started on getting the next appointments, because that's the hard thing about being in our position. When you give people the results and then you can't can't get them to the next step. You're already tied into a whole cancer center where the next step happens naturally. But I think for a lot of people, it doesn't. And that can be like the worst thing for patients is like, you know, what do I do now? And what you don't want them to do is like start going on Google and like just, you know, reading all kinds of things that don't actually apply to them and their situation, and, you know, have themselves planning for something that really doesn't even, you know, apply to what you've just diagnosed them with.
Mhm.
Right. So I have another set of questions, which is about lay letters, right? So there isn't anybody, I don't think, watching this summer series that doesn't know that we in breast imaging have to send everybody a lay letter. That's what the FDA requires. For all of you, who wrote your lay letters? Are you using a template that came out of the ACR, or did you write it yourself?
I wrote ours at our old place, and I started with the ACR as a template. And then I also had to look at what was required by my state, because that requirement changed during my tenure, and what would fit on a single page. There was a lot I wish I could have put in there, but we wanted to keep it on a single page. And so it was actually really hard to meet all three of those requirements.
I agree. Anybody else?
We use the ACR template, and then with the required language for breast density.
And we did too. We used that as a template. We tweaked it a little bit to just, you know, make it a little simpler. And we also have the Spanish version for our county patients.
You just read my mind. I was going to ask about that, whether people are sending it on other languages. Do you send out a letter for everything or just for mammography? So we're required to send a letter for mammography, but do you send out letters for ultrasound and MRI as well?
Yes.
Does everybody? Yeah, we do as well. Does anybody know what the reading level is of their letter, or what the reading level is of the ACR letter? Yeah, it's above 8th grade. And I think, you know, it's something that I keep wanting to work on to try to get that letter down to a reading. We are sending it out in both English and Spanish, which I think is like a really nice, like, first step towards making it more accessible, but it probably needs to be simpler. And especially now that patients can see their actual report online in a lot of cases, if they want to see, like, I find the lay letters a lot of times don't say that much different than what the original report said.
Yeah.
And so there may be an opportunity going forward as patients have the ability to read the original report to really make the lay letter be something that that's accessible to everybody.
Yeah.
And but no one here has done that exercise, has really like tried to do it. No, I haven't either, but it's on my list of things to do. And I get, again, especially since more and more people are reading the original letter, like I feel like there might be some space in there. What about the original report? Are you cognizant of the fact now that patients are reading the report that was intended for their physician on the patient portal? And has that in any way impacted the verbiage that you're using on your reports?
I think that's a great question. I try to stick to the BIRADS lexicon as stringently as possible. But, you know, if I see a mass, well, we all know that could be nothing. It could be a cyst. But just the word mass to a patient is alarming because they don't realize that mass doesn't automatically equal cancer. So for things that I'm calling back, especially if I think something's going to be bad, really, really bad, I will hold on to that to the end of the day and then go talk to my techs who are going to be making the calls and say, hey, look out for this patient. Call them first and then let me know. And then I'll release it because I don't want them sitting at home or in a parking lot or something and reading these really scary words before we have had a chance to give them the plan for those scary words. So I've actually changed how I read. I don't just hit send, see you later on every single report. If I'm calling something back and it has something more than an asymmetry or calcifications, I'm going to hold on to that if I think it could be disturbing to a patient.
Okay, is anybody else doing that? Because that's really interesting. And it's so interesting because what people talk about with the 21st Century Cures Act is that when it's signed, then you can't embargo it. But what you've kind of done is embargoed it yourself
Yeah.
prior to signature, which I think is a really interesting way to get around that, so that
Yeah.
you do have some control over when the patient is going to be able to access it. Is anybody else doing that on this call? I think that's really an interesting solution for this situation. So I need to push you further on that.
Okay.
So do you, let's say it's Friday afternoon.
Mm-hmm.
Do you sign those Friday afternoon reports or not sign those Friday afternoon?
I will not. If my texts are already gone, if they're gone for the day and it's like, 5 minutes till 5, then I'll just keep them in prelim over the weekend, because nothing's going to happen on those anyway. The techs are not going to be calling until Monday morning anyway. But that's 2 days where the patient might see it and be festering and like worried about it.
All right, so I need to go back to what Thomas said in the very beginning of this
Yeah.
thing, because she quoted a paper that said the opposite.
Yeah.
So how do we feel about the fact that there is some literature out there that says that patients want to know as quickly as possible, that, they want the result, whether it's good or bad?
Well, I think part of my issue, I want patients to have results as quickly as possible, but if there's nothing they can do about it, if they don't know what it means, it may just mean that they need, a spot compression and they're fine and it's all good. I think that having somebody to talk to about that and putting it into context and being able to offer a plan are all very important qualifiers to the knowing as soon as possible is the best thing.
Yeah.
That's my personal.
Anybody else feel similarly or differently about that?
Mm-mm.
It's hard. I will say that is not what we do. We sign everything. We call everyone. We do end up with some Friday afternoons that get signed that patients could probably look at over the weekend. But I have been thinking about this a lot lately. But I've tried to sort of believe listen, you're weighing two different things. You're weighing the fact that the literature suggests that the patients want the results, and the fact that the way that they're now going to get the results is probably not the way that they were intended to receive it. It's by reading a report that was really not intended for them. It was really intended for another medical professional. And how do you balance those two things, like their desire to have the results and then you're feeling that, it should be explained to them in a way that's patient friendly, not in a way that was intended for another medical professional.
I have some elderly relatives who will bring me their imaging reports, not breast related, just, MSK, whatever. And they're really concerned about the verbiage. They don't understand it. Mm-hmm. And I think that just having somebody say, no, you don't need to worry about that word. It's okay. They're just describing something. That brings a lot of reassurance. And just seeing them worry about things unnecessarily, in that case, them having access to the report to make things better. It made things worse for them in the short term.
Yeah. How do the rest of you feel? Does that come into play? Do you think, even beyond that, do you think about the words that you're using?
I think about the words a lot.
Yeah.
And this actually happened quite soon after we finished fellowship years ago. One of my former co-fellows reached out to say that a patient had seen in their report where the radiologist wrote, the patient has breast pain that's bilateral, diffuse, worse around the time of their period, likely physiologic, and this is benign. And the patient interpreted the word physiologic to be psychological, psychosomatic, thought that the radiologist was implying that this was made up and was very offended. And since then, I feel like my entire practice and career, I've just been really careful about the words and how it can be interpreted. But that also means that my reporting, I think, is modified. So ideally, I would write all of the findings and then match them up with the impressions. But now I tend to put some of the impressions within the finding. If something is benign and it won't get spelled out in the impression that it's benign, I'll say, this is an oval, well-circumscribed mass that is a benign cyst, right? So put it right there in the finding immediately to tie up that loose end for the patient. So it doesn't just say an oval mass, and then they have to try to match it up at the bottom to say that was a cyst.
So like one of the hardest things for patients isn't just about, and you're exactly right, isn't just about understanding the words, it's about understanding the way that we report.
Exactly.
You know, on like radiologyinfo.org, they actually have a whole thing for patients of here's how to understand how a radiology report is structured. Because while that structure makes total sense to us, the clinical history, the impressions, the findings, the impression, the recommendation, to a patient, that's not a natural way of speaking.
Absolutely.
A natural way of speaking is the way that you're talking about it. You see something, you make a conclusion. You see something, you make a conclusion. You don't see a bunch of things, then wait a whole bunch of time and then have a conclusion at the end. That's confusing for patients. And even the words that we use, I love that physiologic story, although it's terrible, but I love that happened because I had a friend recently I was out to dinner with. This is actually a man. He wasn't having breast imaging, but he had a lot of imaging recently. And he turned to me at a table full of people and said, "Hey, Nina, what do you think the most common word is on my reports?" And he had a lot of spine imaging. And I said, "Unremarkable." And he was like, "You're right." And, and everybody at the table laughed and they were like, "How'd you know that?" And I was like, "Because I'm a radiologist." Like,
we had one resident.
Why am I so unremarkable? He was like, "Why do you guys keep saying I'm so unremarkable?" And I was like, "No, I know it's funny and it's kind of insulting, right? Like, it's
yeah." Well, we had one resident show us a PowerPoint that the hospital sent out to everybody about the words they can use and not use. And they said to avoid complaints of, and say the patient reports, instead of complains of. And the other one that Sandy was talking about was that instead of use the word patient refuses a mammogram, patient declines
that's what I do.
a recommendation for a mammogram. And just soften it up.
Yeah. And I think even when we have those cases where the images are suboptimal due to positioning, I won't just say it's suboptimal due to positioning. I'll say despite patients' best efforts, right? They typically, sometimes you have patients who have decreased mobility or frozen shoulder and they're trying, but I think that helps to show that we recognize that the patient is a partner in their care.
Absolutely. So Miff is writing right now that she was taught in training that the body of the report was the radiologist talking to a radiologist and the impression is talking to a clinician. But the truth of the matter is the entire report now is us talking to the patient, whether we like it or not, they're reading that entire thing. And we're just going to have to, think about that, and especially with these portals. I don't know whether, so I don't know whether you guys have seen any of the products that are out there, not just for breast imaging, but just in radiology in general to try to address this. People are doing things like, including, links to more information about the thing that you're reading about. I love that scan slated product where you can actually just like hover over a word that you don't understand and that word will get defined, or sometimes it'll actually put up an infographic to explain to you what that word looks like. In breast imaging, we don't have that much anatomy to worry about. So it's not, I don't think we have so much of that, but I think in radiology in general, we have a long way to go because whether we like it or not, people are going to be reading these reports. And I think we should like it. Like, I think what we should do is just embrace it and make those reports be something that we would feel equally comfortable having a patient look at as a physician look at. And if it's not, I think we need to stop and say, why not? We want to be able to partner with patients and have them be engaged in their care. We shouldn't use language that is going to make it difficult for them to be able to partner with us in their care.
I agree.
I think breast imagers are way ahead though when it comes to this kind of stuff. I loved talking to you guys because, like I said, this being patient-centered, and I don't mean this is an insult to anybody in any other part of radiology, but being patient-centered is something that we embraced a long time ago. And now we're just tweaking it, right? To just make it even better. But being patient-centered is our thing. All right, so we have basically a minute left. Any final thoughts from anybody on here? This has been a great conversation. Thank you all so much for the conversation. Great ideas. Anything quick? Anything anybody wants to say?
Thank you for your questions. Thank you for being our leader. Thank you.
Well, listen, thank you all for joining me. And we have another, for anybody watching this, we'll be back again next week. I can't remember what the topic is, but we're here every week for the rest of the summer at this same time, Wednesdays at 7 o'clock Eastern time. having great conversations with experts in breast imaging who are willing to be honest and open about the practices where they are. And thank you all so much.
Thank you.
Thank you.
Thank you.
Bye.